Imagine that moment, the quiet anticipation of new life, a mare getting ready to foal. It's really a marvel of nature, isn't it? But sometimes that amazing process can hit a snag. It can turn into a critical challenge, a real race against the clock. Today, we're diving deep in something called equine dystocia. That's the clinical term for a difficult birth in mares. And this isn't just like a small complication, it's actually one of the most significant and time sensitive obstetric emergencies you can find in the whole animal kingdom. So, our mission today is to kind of cut through the jargon and give you a solid understanding of this. We'll explore what actually causes these difficult births, pinpoint why acting fast is so crucial. We'll also look at the signs you need to spot immediately and then unpack the different ways vets can step in to quite literally save both the mare and her foal. Yeah, and we're basing all this on some really comprehensive veterinary sources covering dystocia, emergency management, the whole deal. So stick with us. We'll give you the key info, maybe some surprising facts, and definitely some crucial takeaways on this vital topic. Okay, so before we get into what can go wrong, maybe we should first establish what right looks like. What are the key stages of a normal foaling?
That's a great place to start because understanding normal is key to spotting abnormal, right? Equine birth, or parturition, it's actually incredibly precise. It's generally broken down into 3 stages. Stage 1 is basically preparation. This is the mare getting ready. It usually takes about 2 to 4 hours. Though, for a maiden mare, one having her first foal, it might take a bit longer.
Okay, what kind of signs would you see then?
You'll see things like mild colic signs, restlessness. She might be sweating a bit, maybe some nesting behavior, trying to get comfortable. Frequent urination is common too. Inside, her cervix is relaxing and uterine contractions are starting, gently nudging the foal into the right position for birth. This stage ends with what everyone calls the water breaking. That's the rupture of the choriolantoic membrane.
Right, the water breaking. And then stage 2.
Stage 2 is the big one, the expulsion phase. This is really the critical stage, the one where the clock starts ticking for intervention if things go wrong. It kicks off right when the water breaks and ends, ideally when the foal is fully delivered. Normally, the foal comes out head first. That's anterior longitudinal presentation. Its back should be towards the mare's spine, the dorsosacral position. And crucially, its head, neck, and front legs should all be extended, almost like a diver, right? Streamlined.
Like a diver, I like that visual. How quickly should you see something?
Very quickly. Within just 5 to 10 minutes of the water breaking, you should see the foal's front feet at the vulva, one foot usually a little ahead of the other. Then the nose follows right after. And the entire foal should be delivered within, get this, 15 to 30 minutes after the water breaks.
15 to 30 minutes, that's incredibly fast.
It is, and that's a critical point for anyone watching a foaling. Any significant delay beyond that 30-minute mark, even just a few minutes, technically counts as a dystocia. It signals something's wrong.
Wow. Okay, so that's stage 2. What's stage 3?
Stage 3 is the placental expulsion. This is just the mare passing the fetal membranes, the afterbirth. This should happen within about 3 hours after the foal is born. If it takes longer, that can cause serious problems for the mare, like infection or laminitis.
Okay, so those timelines are incredibly tight, especially stage 2. So let's define dystocia a bit more clearly then. What exactly counts? And how common is it, really?
Right, so dystocia is formally defined as basically any difficult birth where the mare needs help to deliver the foal. Or, like we just discussed, when there are those deviations from the normal timing of the labor stages. As for how common, the incidence rate is around 10% of foalings overall. It does seem to be a bit higher in some breeds, like miniature horses.
Oh, interesting. Why miniatures?
It's likely due to fetal proportions. Sometimes their head or limbs are slightly disproportionately large compared to the mare's pelvic size. But really, dystocia can affect any mare, any breed, any age. The absolute core message, the thing everyone needs to understand, is that dystocia is always an emergency. There's no wait and see.
Always an emergency. That urgency really underscores why knowing the signs is so critical. Which brings us to the next point. Let's unpack the why. Why do these difficult births happen? What's actually stopping the mare delivering normally?
Okay, so the vast majority of the time, we're talking over 90% of cases, equine dystocia is actually caused by a problem with the foal itself.
Over 90%. That's surprising. I might have guessed it was more often the mare.
Yeah, it's overwhelmingly fetal origin. We're mainly talking about the foal being in the wrong presentation, like which end is coming first, or the wrong position, its orientation relative to the mare's pelvis, like upside down, or most commonly what we call malposture.
Malposture, what does that mean exactly?
Malposture means the foal is generally lined up correctly, but its limbs or head are folded or flexed incorrectly. And a big reason for this, kind of surprisingly, is just the anatomy of the equine fetus. They have really long limbs and long necks relative to their body size. Getting all those long parts coordinated and extended through the mare's birth canal is, well, mechanically challenging. Think of trying to maneuver a big, awkward sofa through a narrow hallway.
That's a great analogy, the gangly sofa problem. So what are the specific ways that posture can be wrong?
Well, the most common ones involve flexion. The head and neck might be flexed, so turned off to the side or tucked down between the front legs, or even bent right back over its body. You can also have carpal flexion, where a knee is bent, or shoulder flexion, where the whole front leg is retained back. If the foal is coming backwards, you might see hock flexion. A particularly tricky one is hip flexion, sometimes called dog sitting or a true breech, where the hind legs are tucked up onto the foal's body instead of extending backwards.
Wow, okay. Lots of ways for those long limbs to get tangled up.
Exactly. And there are other fetal causes too, though less common. Things like fused joints or hydrocephalus, which is fluid on the brain making the head too large, or anasarca, where the whole foal is swollen with fluid. Then you have incorrect positioning, like the foal being upside down, what we call dorsopubic or a sideways dorsoileal. And incorrect presentation, like a true breech, where the tail comes first, or the really rare but severe transverse presentation, where the foal lies crossways in the uterus.
You mentioned foal size earlier. Is a foal just being too big a common issue?
Actually, fetal-maternal disproportion, the foal just being too big for the mare's pelvis, is pretty rare in horses compared to, say, cattle. It can happen, but it's not a leading cause. Also, if a fetus has died before labor, it often lacks the muscle tone needed to get itself into the right position. And twins, while rare to survive to term, can cause a blockage if they try to come out together.
It's fascinating that fetal issues are so dominant. What about the mare? What can go wrong on her side?
Maternal causes are much less frequent, probably less than 10% of dystocias. But they do happen. You can have uterine inertia, where the uterus just doesn't contract strongly enough. This can be primary, meaning it never really started properly, or secondary, meaning it got exhausted from prolonged labor. Sometimes the cervix doesn't dilate properly, or there might be physical obstructions like old pelvic fractures that narrowed the birth canal, or scar tissue from previous injuries.
So physical blockages.
Right, or things like uterine torsion, where the whole uterus twists on itself, cutting off passage. Even things like severe abdominal wall damage or a hernia could potentially interfere with the mare's ability to push effectively. And sometimes systemic illnesses in the mare, like fescue toxicity, can play a role.
Okay, so putting all this together, for someone watching a mare approach her due date, what are the absolute must-watch for signs? The things that scream problem even before you call the vet?
This is where the concept of the golden hour really comes into play. Rapid recognition is everything. The longer a dystocia goes unaddressed, the worse the outlook gets for both mare and foal. Survival rates plummet. So an attentive owner or attendant is crucial. Key things to watch for. First, the water breaks, but you don't see any feet or a nose at the vulva within, say, 5 to 10 minutes. That's a major red flag.
5 to 10 minutes.
Second, the mare is actively straining, really pushing hard for maybe 15, 20, up to 30 minutes, but there's no real progress. The foal isn't advancing. That's another big warning sign.
So straining without results.
Exactly.
Yeah.
Or you see something abnormal at the vulva. Maybe only 1 foot appears, or maybe you see the foal's tail first, or some other part that clearly isn't the normal 2 feet and a nose presentation.
Got it. And you mentioned something earlier, the red bag.
Yes, the red bag delivery. This is an absolute 5-alarm emergency. It requires immediate action, often by the person right there on the spot. This is when you see the choriolantois. It looks like a thick, velvety, bright red membrane protruding from the vulva before the water has broken, before you see the foal or the clear amniotic sac.
Why is that so critical?
Because it means the placenta has detached prematurely inside the mare. The foal's oxygen supply is cut off. It's suffocating. If you see a red bag, you have to immediately, carefully but firmly, rupture that red membrane yourself and then assist in getting the foal delivered as quickly as humanly possible. There's no time to wait for the vet in that specific situation. You call them, but you act first.
Wow, okay, that's vital information. So assuming it's not a red bag, but one of the other signs appears, the vet arrives, what's their diagnostic process look like?
It needs to be fast but systematic. They'll do a quick check of the mare's overall condition, heart rate, breathing, mucous membranes. Is she stable? Then, really important, is quick but thorough cleaning of the mare's perineal area. You need to be as sterile as possible. Then comes the vaginal exam. With a sterile, lubricated glove, the vet reaches in to figure out what's going on. They're checking. Is the cervix fully dilated? What's the foal's presentation, position, and posture? Exactly how is it lying in there?
And can they tell if the foal is still alive?
Yes, that's crucial. They'll try to elicit reflexes like a suckle reflex if they can reach the mouth, a withdrawal reflex by pinching a limb, or a corneal reflex by touching the eye. They might feel for a pulse in the umbilical cord or see eye movements. They also assess the foal size relative to the mare, check the integrity of the mare's reproductive tract for any tears already present, and feel the uterine tone and lubrication level, which gives clues about how long things have been stuck.
Okay, so once the vet has figured out the what and the why,
Mhm.
what can actually be done? What are the options on the table for treatment?
Right, the goal triad is always save the mare, save her future fertility, and if possible, deliver a live, healthy foal. The approach depends heavily on the specific problem, how long it's been going on, full viability, and what facilities and expertise are available. The first line of attack is often assisted vaginal delivery, or AVD. This is usually done with the mare standing, maybe with some light sedation to keep her calm, and often a caudal epidural.
What's the epidural for?
It helps reduce her straining, which makes it easier for the vet to work. It numbs the area without making her lie down.
Uh-huh.
Copious amounts of sterile obstetric lubricant are absolutely essential here. Then the vet uses techniques called mutation, which is basically manually repositioning the foal, like turning the head or extending a leg.
The gangly surfa maneuvering.
Exactly. And repulsion, which means gently pushing the foal back a bit into the uterus to create space to make those corrections. Once the foal is repositioned correctly, gentle traction is applied, usually with sterile obstetrical chains placed carefully on the foal's legs, timed with the mare's contractions. But there's a time limit. You really only want to be actively manipulating for about 10 to 15 minutes with AVD. Any longer risks too much trauma.
Okay, so if that doesn't work or isn't appropriate,
Then the next step might be controlled vaginal delivery, or CVD. This requires general anesthesia, putting the mare completely under. She's placed on her back, in dorsal recumbency, and often her hindquarters are lifted, sometimes with a hoist.
why lift the hind end?
It's a game changer. Gravity helps pull the foal deeper back into the abdomen, away from the pelvis. This gives the vet significantly more room to manipulate those limbs or head. It can make a difficult correction possible. They might also give drugs like clenbuterol to help relax the uterus temporarily.
Makes sense. And if even that doesn't work or isn't the best option from the start, is that when a C-section comes in?
Precisely. A cesarean section, or C-section, is the surgical removal of the foal through incisions in the mare's abdomen and uterus. It's indicated if AVD or CVD fails, or if it's clear from the start that vaginal delivery isn't possible. Maybe the foal is truly too large, or there's an irreducible uterine torsion, or a severe fetal abnormality. It's also chosen sometimes when vaginal delivery would likely cause severe trauma to the mare, or when getting a live foal out quickly is the absolute top priority.
Is there a significant downside to a C-section for the mare, maybe for future breeding?
It's major abdominal surgery, so there are inherent risks, anesthesia complications, infection, post-op pain, recovery time. Fertility-wise, mares can certainly breed again after a C-section, but conception rates might be slightly lower, especially if bred back in the same year. Waiting till the following year often yields better results, maybe in the 50–70% success range. It's definitely a consideration.
Okay. Are there other options besides vaginal delivery or C-section?
Yes, there's phytotomy. This is an option only if the foal is confirmed to be deceased. It involves surgically dismembering the dead foal within the uterus, using specialized instruments, and then removing it in pieces through the birth canal.
That sounds intense. When would that be chosen?
It's indicated when you have a dead foal, and the dystocia can't be corrected by manipulation for a vaginal delivery. Or perhaps when a C-section isn't feasible, maybe due to cost, lack of surgical facilities, or if too much time has passed, making anesthesia too risky for the mare. Sometimes it's actually preferred over a C-section if the mare's future fertility is a very high priority, as it avoids the abdominal surgery and uterine incision, provided it can be done without causing excessive damage to the mare's reproductive tract. And then, sadly, in some very severe, prolonged, or traumatic cases where the mare's prognosis is grave, euthanasia has to be considered as the most humane option.
A very difficult decision, I'm sure. So let's say the foal is delivered, one way or another. The immediate crisis is over, but I imagine the work isn't done yet. What kind of aftercare is needed?
Absolutely. Post-dystocia care is intensive and critical for both of them. For the mare, the vet will do a very thorough exam of the uterus and birth canal, checking for tears, bruises, or excessive trauma that might need surgical repair. Uterine lavage, Basically, washing out the uterus with sterile fluids is often done to remove blood clots, debris, and contaminants, helping prevent infection. She'll usually get small, frequent doses of oxytocin. This helps the uterus contract down, expel any remaining fluid, and importantly, encourages the expulsion of the placenta if it hasn't passed already.
Right. You mentioned retained placenta earlier.
Yes, it's the most common complication. If those membranes aren't passed within 3 hours, it's considered retained, and that significantly increases the risk of metritis, which is a nasty uterine infection, and potentially life-threatening laminitis. So monitoring for placental passage is key. She'll also typically be put on broad-spectrum antibiotics to prevent infection, anti-inflammatories like NSAIDs for pain and inflammation, and possibly IV fluids if she's dehydrated or showing signs of shock.
What other complications do you watch for in the mare?
Besides retained placenta and metritis, we worry about severe lacerations or even rupture of the uterus or cervix, significant hemorrhage, nerve damage. Sometimes the nerves controlling the hind limbs can be bruised from prolonged pressure, causing temporary or even permanent weakness and colic.
Okay, and what about the foal? Assuming it was delivered alive, what's the immediate focus?
For the foal, it's all about immediate neonatal assessment and resuscitation if needed, checking breathing, heart rate, reflexes, the basic ABCs. And then, absolutely crucial, is colostrum. That first milk is packed with antibodies the foal needs for immunity. Foals born after a dystocia are often stressed, weak, maybe slow to stand and nurse, putting them at very high risk for a failure of passive transfer or FPT.
Meaning they don't get enough antibodies.
Exactly. They don't absorb enough IgG from the colostrum. This leaves them highly vulnerable to infections. So, ensuring they get good quality colostrum, either by nursing or bottle tube feeding, within the first few hours is vital. We often test their IgG levels later, and if they're low, they might need intravenous plasma transfusion to provide those essential antibodies.
What other issues might these foals face?
They're at higher risk for several things due to the stressful birth. Hypoxia, or lack of oxygen during the dystocia, can lead to neonatal maladjustment syndrome, often called dummy foal syndrome, where they show neurological signs. Physical trauma is also a concern, things like fractured ribs from the delivery manipulations or nerve damage. Infection or sepsis is a major risk, especially if they had FBT. And sometimes they can have difficulty passing their first manure, the meconium, leading to an impaction. So they need very close monitoring.
It sounds like a really intensive recovery period for both. So, stepping back, what's the overall prognosis? What does this all mean for their long-term outlook?
You're right, it really boils down to that. The prognosis for both mare and foal is very directly linked to two main factors: the duration of stage 2 labor and the amount of trauma involved in the delivery. For the foal, time is absolutely everything. If that second stage from water breaking to delivery is under 30 minutes, the prognosis for survival is generally good, often better than 80 or 90%.
But if it goes longer?
The odds drop fast. If stage 2 lasts 30 to 60 minutes, full survival might only be in the 30 to 60% range. And if it goes over 60 minutes, the prognosis becomes poor, often less than 20% survival. And even those foals that do survive are at high risk for those complications we talked about: dummy foal syndrome, sepsis, needing intensive care. And of course, if a phytotomy was performed, the foal is already deceased.
That's a stark reality. What about the mare's chances?
For the mare, survival prognosis is generally better, especially with prompt and skilled intervention. For assisted or controlled vaginal deliveries, survival is often over 80–90%. For C-sections, it's maybe slightly lower, around 70–85%, depending on the circumstances leading to the surgery. Phytotomy, assuming no major complications, often has a good survival rate for the mare. Her prognosis definitely worsens with prolonged dystocia, severe trauma during delivery, or if major complications like uterine rupture occur.
And her future ability to carry a foal?
Future fertility is often quite good after an uncomplicated AVD or CVD, maybe a 60–80% chance of successfully breeding again. After a C-section, as we touched on, rates might be a bit lower, perhaps 50–70%, often better if she's given a year off before rebreeding. Interestingly, fertility after a properly performed phytotomy can actually be quite good, sometimes comparable to vaginal delivery, because it avoids the uterine scar from a C-section. But again, any major complications like a severe metritis from a retained placenta or a significant tearing of the cervix or uterus, those will definitely negatively impact her future fertility prospects.
Okay, so wrapping this up, it seems the overwhelming message is about time. Equine dystocia is just incredibly time sensitive.
Absolutely. It's a critical emergency where every single minute counts. Prompt recognition by owners or attendants and immediate skilled veterinary intervention are just essential. They make all the difference.
It really highlights the delicate balance, doesn't it? How quickly things can change for a new life. Thinking about this race against time and foaling, what does it make you consider about maybe the urgency of expert help in the animal world, or even
Mhm.
how we approach time-sensitive health crises ourselves? What stands out to you about needing to be prepared for those critical moments?